Good morning, everybody. Sorry about the couple-minute delay. I do have a presentation here for kind of a review of pediatric seizures. Also, what we really discuss a whole lot in this presentation is atypical presentations on your seizures and the kids who have diagnoses of epilepsies. Just to make sure we can kind of talk about what's a little bit different with those kids versus your first-time seizures. And so we're going to talk through a number of those topics. I have ADD with the best of them, so if you need to interrupt me, please feel free, especially if you want to talk about the Dallas Cowboys, and we'll be here a little bit longer. So, all right. So I don't have any additional conflicts other than I work for STARS. That is my full-time job, creating the plans and doing the training for the medically complex kiddos. And a number of videos in here were shared by our actual families of their patients. So we're always thankful for them for sharing that with us. And then I'll point out there's a couple of resources that were shared with us by other physicians from other places in here. This is Mr. Gabe in this photo here. He's actually the first patient with epilepsy we ever enrolled in STARS. He was part of the original 14. And he started to teach us some of those really important concepts we needed to be internalizing. First of all, how did we discover him? How do we know he was in our district? Because the family kept calling. And we're all sitting in the ambulance houses and we're like starting to roll our eyes. We're like, what's going on with this family? Why are we going to this house all the time? And as we went and interviewed that family, we discovered all kinds of things we didn't know. So to out myself as a young city medic and a little bit of ignorance that comes with your early days on the truck, just if you were diagnosed with an epilepsy and you were actively seizing, I either assume that you have not been appropriately taking your medications and or you're drinking alcohol. And so hopefully not too many of my 6 and 7-year-olds are out here in the world imbibing like that. And so what we started to really get from that family is that there's many different types of epilepsies, and some of them are just particularly insidious. Like no matter how good the family is at taking the medications, that kid can still have breakthrough seizures. And so we started to learn a lot about that from him. Also, just other cool things in this world. So that is actually his service dog, Lightning, who unfortunately passed away a couple of years ago. But that dog had the ability to go retrieve a set of diastat and bring it to patient's side if he was actively seizing. There was also a button hardwired into their kitchen that activated 911 that the dog could go activate. We do not deserve these creatures. But you might actually encounter a service animal with an epilepsy patient as well. And then there's always that, depending on the situation, we may need to transport and or keep the service animal with that kiddo, depending on situation. So just things to think through. So why talk about seizures? You guys can tell me. You guys are out here in the field. What are the primary reasons we get dispatched to kid calls?
First-time seizures.
Seizures, absolutely. Respiratory distress, trauma, sick case, right? So I give you that that's 95% of your kid calls out here. So if you ever want to be like, what should I study for? Well, there's your bread and butter right there. That's what we're going to spend a lot of our time on. Seizures is still one of the most common reasons we get dispatched. Sometimes dispatched as a seizure, sometimes disguised as something a little bit else, like altered mental status or some sort of Brewy or Alti style event. So just make sure that we want to make sure we're comfortable with what we should be doing for these kids. And despite the fact that a lot of our protocols look the same, no matter which one of your 100 EMS jobs you've been at, since about 2010, a lot of the protocols all read the same at all of those jobs. We still see a fair amount of variation in the treatment rendered to the kids who are delivered to the hospital. So just talking through and making sure we're all comfortable with where we should be at on our medications and our administration. So objectives, we're going to just review a seizure, talk about the seizure types. Like I said, a lot of the videos and parts of this presentation are focused on those atypical presentations. I have a lot of faith in it. If one of you goes on a call right now and you show up and you see a kid fully locked up in a generalized seizure, you're going to be like, oh, he's seizing. But sometimes those atypical ones are incredibly hard to parse out, like what's going on with this kid. So we're going to review a lot on that. Talk about some of the alternative treatments the families are undergoing at home. Make sure we're all on board with the definition of status epilepticus and just review our current pre-hospital treatments. So at its simplest, what is a seizure? It is overexcitation of neurons. They are discharging and setting off the neurons next to them. And you are going to know I'm a paramedic and not an epileptologist by the phrase I'm about to say. When I look at an EEG, what I see is VFib and VTAC. All right? And in EEG world, VFib is the good stuff. That's the normal stuff. And I think that makes sense, right? Like if you put a bunch of electrodes on the outside of my skull cap and are just sort of looking at the general electrical activity going on inside, a lot of it's going to balance out, right? Like I'm thinking about what's on the next slide that I'm about to say. More importantly, what am I going to have for dinner tonight? And also, are the Dallas Cowboys going to win the Super Bowl this year? And I got like lots of things going on in here, and that sort of all cancels itself out. Versus when you see these large spikes that look like VTAC, that is large loops of neurons all discharging at the same time, setting each other off. So that is the seizure activity. And it can either be generalized, where the large majority of the brain material is actively seizing, or it can just be a focal seizure, just part of the brain is seizing if you're only looking at certain leads of it. And whether it's generalized, focal, you might or might not have convulsive actions in the seizure. That all matters whether it hits the motor cortex or not. So one of the important concepts we're going to talk through in a couple slides, though, is that what you often see, focal seizures can become generalized seizures. And we're going to see a couple kids who exhibit examples of that. And this is just the EEG representation of that. This kid was having a focal seizure, and then all of a sudden you see it go generalized as more and more neurons are engaged in the seizure activity. So generalized seizures originate at some irritable foci, some set of neurons that all of a sudden start or initiate the seizure activity and quickly distribute throughout the neuronal networks throughout the brain. And so this is what we're often taught, the classic signs and symptoms of a generalized seizure, where you see somebody have a tonic-clonic actions. Focal seizures, as we'll discuss here shortly, can be just one section of the brain. But as we just mentioned, they can quickly also spread to become generalized across the whole brain. Courtesy of all the stroke training that we do in this day and age, I think we're all pretty comfortable with the idea that if just part of the brain is seizing, you tend to only get effects of what that part of the brain controls. And so depending on where the different focal seizures are, you will get different symptoms that that patient expresses for their seizure activity. And as I mentioned, it does have to hit the motor cortex for you to get a lot of those muscular demonstrations you're used to seeing in seizures. So this is a bit of a busy slide, but I think it's important because it kind of really helped me understand my epilepsy patients and where they come from. So this is actually like the rubric used by the International League Against Epilepsy. Can we just all agree that in disease pathologies we need more international leagues against things? Like that's a pretty baller name. And so the International League Against Epilepsy, this is what a lot of neurologists use to kind of hone in on a patient who is having repetitive, unprovoked seizures and getting them their epilepsy diagnosis. And so yeah, we'll just kind of walk through this practically from our viewpoint. So you guys all get dispatched out to First and Main Street right now for a 6-year-old who just had a first-time seizure. And so you pick them up and you take them to the hospital, and what happens? Yeah, so we'll get a
fever, and did they fall? Have we seen the loss of balance? So that way we know if it's a trauma related or if it's something neurological.
Perfect. So yeah, absolutely. History of the event, kind of rule out some of our main culprits, see what's going on. So we run through that. We might do some basic labs. If we think there's reasonable history of trauma, we might do a scan, make sure we don't got a brain bleed, and then a couple of hours observation at the ED, and we say, well, Mom and Dad, a lot of kids have a first-time seizure. It only happens once. Go home. If it happens again, come back. And if we think the evidence was strong enough for the event, we might say, oh, also you should try to get in to see neurology, whether that's 3 months or 24 months from now, depending on when you can get in to see the specialist. And so, cool. So most patients, a lot of the kids never have another seizure. They just go on about their way. But some might have a second seizure. So you guys all go get dispatched again. You are now dispatched 3 days later. You go back to that same residence for that same kid who had another event. Let's say he had a status event this time. And you transport him in, and what happens this time? That's all right. So now we're probably going to admit him. I'm sorry.
Same thing that happened the first time.
So occasionally, but a lot of times we do take this a bit more seriously now. Like 2 or more unprovoked seizures in a week, we don't have a good explanation of what's going on. Typically, you're going to get admitted and at least get 24, 48 hours observation. Now we're probably going to get you a neuro consult set up and all those kinds of things. Ideally, neuro will set you up with a video EEG or some such study. So now we're going to take it a bit more seriously. So you have now had 2 or more unprovoked seizures, When we take that history of the event, we'll say, okay, was it just focal presentation, or did they have a generalized seizure, or maybe we don't know. And based on that, we're going to try to label them with the epilepsy that we think they have after we've ruled out all the other possible causes of what could have caused that seizure. And we will give them the best name we can. We think, oh, you have this type of epilepsy. And does any part of that sound super highly scientific and specific? Oh. A lot of that is based on just like family reporting history, your trip sheets reporting sort of what happened. And so it is not exactly always a precise science to get that kid to the exact right title of the epilepsy that they have. So when we're diagnosing it, that history that you mentioned, that's the highest level of evidence they'll use to try and give the name. If something's revealed in the neurological examination when neuro's doing their checks, that'll help lead us down the right road. Visualization of the event is number 3, and I think that's more important for you because you might actually witness the seizure as opposed to the hospital staff later. So this is one where whether you can capture video of it or if you need something for mom and dad to do. If you say, hey, mom and dad, I'm gonna control this airway, recovery position, suction, oxygen, BVM if I need, will you guys pull out your camera and get a video evidence, especially if you don't have a diagnosis? You can show neuro or your primary care this later. So have the family capture a video clip of the activity to see if that can help them get a better diagnosis if they don't have one. And then the EEG can also get you to that diagnosis. The problem with the EEG is it's just like the Holter monitor. The patient doesn't act up whenever we're watching them. It's only after they go back home and then something happens and then they call you guys back. And so you get that title. They say, okay, we think you have this type of epilepsy. We think this is the drug that you should receive for that type of epilepsy. And that first line drug stops that kid's seizures 47% of the time. So good for that half of the kids, but the other half will continue to have seizures despite that, being prescribed that drug. So we say, oh, that's unfortunate. Let's try the second drug that we think will help assist control seizures in that class. And that stops the next 13%. So 6 out of 10 kids now have their seizures controlled pharmacologically, but that leaves 4 out of 10 who are going to continue to have seizures. All right, that's when we start to have that discussion of, all right, you're a little bit treatment resistant. Maybe you are a ketogenic diet candidate, or maybe we should talk about a vagus nerve stimulator. Maybe you're a surgical candidate. There's, of course, lots of cultural baggage around the concept of whether you're a surgical candidate to relieve your epilepsy from the old days of lobotomies. I do think this is something you will see come back in more and more, and that's because we have less invasive means of surgery now. And so yeah, I do anticipate within the next 10 to 20 years, you might run on a patient who's like, yeah, we went up to CHOP or we went up to Boston and they did some sort of fancy new surgery and they just resected the little bit of irritable foci that always sets my brain off into seizures. So I think that's a reasonable story you might hear coming up soon, but not quite as common right now for surgical treatments on the kids. So I just want to dispel a few myths. Like I said, especially when we talk about the folk teaching that we often do in EMS, is we spread a lot of knowledge from provider to provider, and sometimes over the years we accumulate some bad knowledge that is passed along through there. So just to make sure we dispel a few myths, is incontinence always present during a seizure? Absolutely not. So first of all, if they don't hit that motor cortex and have complete muscular atonia, they will not release their bladder. You won't see the incontinence. Also, even if they just went to the bathroom 5 minutes before they have the seizure, there was just no urine in there to come out. And so I think while it's a nice cinch in your diagnosis, you cannot depend on incontinence to declare, yes, my patient had a seizure. Is it possible for them to have partial awareness? Absolutely. If they're only seizing a focal seizure in one part of the brain, they can still have a lot of awareness of what's going on in their surroundings and their environment. Are focal seizures only limited to abnormal eye movements? No, you saw that from the brain with all the different symptoms. They can have all kinds of different presentations of that. And do you feel that children often fake seizures? If I remove high school from this question, are we on board? Yeah. I'm not of the belief that your average third grader is trying to get out of their math exam by like faking a seizure there. And I will point out that even if you're going to high school, for somebody acting a darn fool because they saw a YouTube video last week, a benzo might not actually hurt the situation a little bit. Dr. Brandt, earmuffs, sorry. Okay. Okay. So yeah, I do not feel that children are often faking seizures. We need to default we think this was seizure activity until proven otherwise if we're receiving that story or that history. So we're going to watch a couple of the videos that we got from our parents, with the exception the first video actually comes from Dr. Larry Mellick down at University of Alabama. And I think the first one, like a little neonate seizing, is probably the scariest thing, and that's why it comes with scary music, so I just want to preface that a little bit. A couple things I want you to really pay attention to while we watch the videos. Something you're always looking for, first of all, of course, whatever we think is indicative of the seizure activity. Despite that, what's their respiratory status? Do you see regular respirations and good coloration despite the seizure activity, or are you seeing them start to desat, taking really irregular or really shallow respirations? So we'll just kind of focus on a few of these real quick. Let's see if we can't dial that down a little bit.
And that's, okay, so.
All right, so how's my skin color doing? I think we're still pretty pink there. All right, what about the chest wall? Regular respirations, irregular respirations? Fair enough. I think we're pretty regular for just a few day old. That's not too bad, right? Like they have trouble remembering when to breathe on time anyways at baseline.
Point one. Now she may be coming out of it now.
Cool. So like that. So what was the first thing he said, or he checked whenever he walked up to her and thought she was seizing?
Yeah, now I think
Yeah, absolutely. He tested that muscular tonicity in the extremities. Like, is that got play in it? And she was pretty rigid, like the whole body moved. So what does he do the first time he goes and says, I think she's coming out of it? The first thing he does is just goes and checks that same symptom and what he thought, and all of a sudden you got play in that arm. So I think that's just a valuable thing watching who's obviously a skilled care provider. Like, okay, that makes total sense. Let me go double check my assumption or why I thought this kid was seizing. So that was kind of a neonatal spasm. What you noticed in that video, you did not see what we're traditionally used to in the adults, right? Like we are used to that generalized tonic-clonic where they pull their arms up and extend their legs out. Kids often don't give you that presentation. A lot of times they have these atypical movements where they'll just pull one arm in and extend one leg, or sometimes they'll throw out both arms and bring both legs up, or vice versa. But a lot of that's because kids aren't as neuromuscularly well developed. They aren't as well connected as we are, and so they tend to have different presentations even when the muscles are moving than some of the adults that we're used to. This is my buddy Cade, who has Wolff-Hirschhorn syndrome. It's actually a metabolic syndrome, but it's often accompanied by epilepsies. And unfortunately, he has a long history of status epilepticus events.
Okay. Hey. Hey. Hey, buddy.
How do we feel about skin color in this kiddo? That looks a little paler than I like. There's a little, maybe some lips are a little blue. And I really want you to pay attention to this arm movement because we're going to talk about that in just a second. I know we don't have his chest exposed, but respirations, I mean, yeah, mouth, I think we're pretty irregular here. All right. So some things that stand out to me, you can see a little bit of lip quivering going on there as well. But this is a kid where like if I, at least especially when I started my career, if I didn't have a parent sitting there telling me like this is him seizing, like this is what it looks like, I'd be like there's some weird stuff going on here, but I don't know that my mind would jump to like, oh, this is an active seizure that's happening. So a couple of those atypical clues, a lot of times if you get that oral motor movement, especially if it's repetitive, whether that's tongue thrusting, lip smacking, that can be indicative of the seizure. You'll see him do his tongue thrust a little bit there. The other thing you witnessed there, it was the figure of 4. So this is a classic seizure sign, especially where it's really notable. It's patients who are having a focal seizure that's spreading to become a generalized seizure. And what you'll see is they'll stop talking to you, always an ominous sign, right? And then what you'll see is your patient will go rigid and they will pull one arm up to the opposite elbow. It looks like a figure of 4 from above. The other sign that sometimes can be indicative of this is the fencer's pose. You'll see especially the little kids will pull up and give you kind of a fencer's pose. Now, just to be clear, that is a normal reflex in brand new babies. That's one of the cute ones. We're like, oh, he startled and he fenced and he did all that stuff. But after a couple months of age, that's not a normal reflex to still have in place and can often be indicative of seizure activity going on underneath. Something that you saw, I don't think I have it in this lecture, but I have another video of him seizing where you can actually just see dad stimulate him to breathe the whole time. Like you'll see dad like walk up and just rub his chest and like, hey buddy, take a breath. And the kid goes, oh. You're like, holy crap. You're like, hey buddy, take a breath. They're like the kid's like a breathing on demand valve breathing. And so I think a couple of good clues there, like just things you can add to your skills, your repertoire. If you have a kid you think is seizing, first of all, expose their chest wall so you can see if they're taking good respirations or not. And then also just drop your hand on their chest. See if you can't feel for adequate depth. You might actually be able to stimulate them to breathe. Something my respiratory therapist partner always reminds me, if you've already taken the time to expose the chest, go ahead and thumbprint the sternum, get a central cap refill, see if it just pops back, see if they're oxygenating themselves okay through it. All right, this is my buddy Cade during a drive. So that's a little more clear to me, right? I'm like, oh, that's a little kid seizing. So eyes are fixed, deviated just a little bit. That active motion, you can almost hear that grunting. Yeah, that is he's moving his mouth there. Awesome. So a couple of things you probably couldn't quite hear the audio super well. One of my favorite parts as always is mom says we need to pull over and the first thing you do is hear dad hit the accelerator. So just that's how we're wired, gentlemen. That's all right. Secondly, so the other thing she's saying is, when you pull over, we need to put oxygen supplies on. And so something that I like to remind people is that our parents are going home with orders and with medical equipment and with instructions for what to do if their kid has an emergency. And especially for kids that we know desat during their seizure episodes, parents will have O2 supplies there. So sometimes you're gonna show up, that's one of the reasons they might already have a nasal cannula on, it might already be flowing. Also just sometimes, like, I hate to say it, but we all have had those partners who are like, you guys are already doing everything, why are we here? Like, first of all, let's talk to those people. But also, those parents were following very specific discharge instructions. They had instructions at home that said, if your kid seizes for 5 minutes, administer a dose of Diastat. If he's still seizing 5 minutes later, administer a second dose of Diastat and call 911. If at any point during his seizure he starts to desaturate or you put the pulse ox on and he is below 94%, add 2 liters of oxygen. If at 5 minutes later he is still desatting or turning blue, up the oxygen and call 911. So parents are being given orders and outs. I often joke that when you're running children with medical complexity, children with known extensive histories, those sometimes are closer to a transfer than a 911 call, right? Like you're showing up to a set of parents who's like halfway through the call with you and you just need to say like, what have you guys tried? What do we need to move on to next? And then we'll be your wheels to get you to the next set of treatments. All right, so this young man really exhibits that example of that tongue thrusting. And then he also does, you can see where he does the arms out and the legs up or vice versa. So that rhythmic tongue thrusting can be very indicative of a kid who's having a seizure. And I think that's important because once again, that's where like in my younger career, I've been like, I don't like know what's going on with that kid, but that doesn't look like what the book said a seizure looked like. So I don't know that I would pick up on that. So I think it's important to see that kind of atypical presentation. All right, so my buddy Kate again. First of all, sweet scalp IV. Kudos to whoever got that. If we start scalp IVs, which direction does the needle advance? Always towards the heart. Always towards the heart. All right, perfect. Some other things that outside of IV excess that this reminds us of. So of course we have oxygen on him, but we have that evidence of all that saliva pooling. If you are actively seizing and you're not well controlling the muscles in your oropharynx, particularly the ones, the swallow reflex and controlling your airway, they do tend to pool secretions. Also for the chronic seizure kids, some of the medications we give them tend to lead to excess saliva. And so super common, that's why you kind of see them on his side. That's why we put patients in recovery position, especially till we can get our fancier tools out where we might just suction them out to help clear all that saliva out of there. But BLS before ALS, get them up on their side and help drain some of that extra saliva out if they're not clearing their airways well.
Baby, it's okay. She has epilepsy. If it lasts much longer, then. Thank you.
How's my coloration doing?
You okay, sissy? You okay, sissy?
Cool. So she's a little paler and bluer than I would appreciate in most of my patients. Also, something else I like to point out in this video, Mom Master, you doing okay, sissy? What'd she do? She nodded her head within like a second and a half of watching the end of the seizure activity. And then Mom asked it again, and she nodded again. So while sort of like incontinence, the postictal period is really nice to cinch in that, yes, my patient had a seizure and I know it because of this, but you will not always see that postictal phase. And some of that's, especially in focal seizure, they can be aware of their environment and they start to respond really pretty quickly back with their care providers after the seizure. So you can't just depend on that like, oh, he's acting weird, but he started talking right away, or he nodded his head yes. That clearly could have been a seizure. That is just a outright example of they can interact pretty quickly sometimes coming out of that. So same young lady. So she has Lennox-Gastaut syndrome, which is notorious for different seizure presentations in different events. And so you can see this is very different from her first one.
Scarlet.
Can you look at Daddy? Where's Daddy at?
Her heart's racing, Aaron. Scarlet.
So once again, another harder one to tease out if you don't have somebody there kind of telling you. I mean, the eye deviation's the main thing that I've got going on there. And you can see she even tries to come back a couple times when they're talking to her, but that disconjugate gaze and keeps going back up and to the right. I would argue that she doesn't desat as badly in this event. Still got pretty good skin color there. But once again, you see the parents are doing that. I recommend that as a tool to you to add to your repertoire. Put your hand on their chest. You immediately get a sense of regularity and depth on the ventilations, and you can kind of try to stimulate them to breathe just a little bit. So this is an example of an absence seizure. Of course, we used to have petit mals and grand mals and absence seizures until they finally figured out we don't all speak French, and so now we have generalized and focal seizures. And so this is what in the old days would have been called an absence seizure. What are some clues that my patient's seizing? Yeah, absolutely. I've got that consistent eyebrow twitch going on. Rapid blinking. Yeah, and I almost have like stimming-like behavior, right? Almost.
What are you doing? Abby? Abby? Abby?
I just want to have something to show you.
Abby?
If I walk in on the wrong moment of that call, I'm going to take a way different impression out of all that, right? So, but I think also kind of indicative of that, like she knew her mom was trying to talk to her. Like she was probably trying to answer, and then once she finally has the ability to speak again, it comes out as a big long whine, right? So, so absence seizures are actually generalized seizures that don't tend to hit the motor cortex, so you don't have some of the big movements that we're used to seeing. But it still usually is near whole brain seizing. So I've never particularly envied our epilepsy patients. I think it's a challenging disease to deal with. The idea that I might not be able to go to the grocery store and not wake up in a circle of strangers and have urine in my pants, like that gives me anxiety and terror just thinking about it. And on top of all that, we know there's a couple of other complications that come along with the disease. So on average, it's been proven statistically that most epilepsy patients are about 10 IQ points behind their peers. I think there's a number of reasonable explanations for that. First of all, if you're diagnosed with epilepsy, you've got to go see specialists. You get pulled out of school pretty frequently. Also, I can only imagine it's a little hard to sit there and learn if you're watching your teacher teach about George Washington and you kind of fade off and you come back and she's more going on about subtraction. On top of that, we're giving you drugs that affect the way your brain works, but that's not uniform throughout the day, right? Like they might come on strong in the morning and fade in the afternoon, and so you're kind of dealing with a really dynamic brain under that. It's just hard to keep up with your peers. Also, you have the comorbidities of like brain malformations or other things that might cause the seizures that come into those statistical populations. We know that they have a higher risk of depression and a higher risk of suicide risk. We've already talked about where anxiety might come from. I have anxiety for them. We, of course, have the risk of accidental injury. You seize while you're driving a car. You seize while you're doing the dishes and cleaning the knives. There's risks there. And on top of all of that, what we have is the sudden, unexpected death of the epilepsy patients. Unfortunately, for reasons we don't fully know or understand yet, a lot of epilepsy patients tend to die before their peers, ruling out and controlling for the seizures. So it wasn't because of the seizure, but we just know that they tend to die a few years ahead of their cohort. So we give you lots of medications to try and control your seizures, but I think it's kind of important to think of these in the same way that we think about the psychotic drugs, right? And so are the antipsychotic drugs. And so we are playing around with brain chemistry, and that is not always precise science. Like if you give me somebody with high blood pressure and we can put the art line in and do labetalol, and we're like, oh, we know exactly how to tweak this in. When we give you drugs that affect your brain, a lot of times it's like, hey, try this out for 6 weeks. Make sure you stay consistent on your drugs, and we're gonna ask in 6 weeks, how's everything going? Do you feel like you got good control of this or not? Some of those drugs we give him, because they do affect the way the brain works, have some particularly nasty side effects: increased lethargy, nausea, irritability, impulsive behavior in a group of patients we just said were at risk of increased depression and suicide risk, constipation and hypohidrosis, which is the lack of the ability to sweat. Especially for like sodium channel blocker drugs. Of course, we're aiming for the ones up here, but you can have some systemic effects from the drugs that we're giving, so you can have other body effects. That is noteworthy too, because if the drug takes away their ability to sweat, what's one of the primary instigators of seizure activity? Heat, hyperthermia. Yeah, so we took a group of patients and now they can't cool their bodies off the natural way. There's a little bit of increased risk there. A lot of these are first pass liver drugs, so you got to worry about the liver. And then some of the drugs have a side effect of anxiety and depression, which I think we can all agree is just increasingly challenging. Seizure action plans, I already kind of briefly alluded to some of this, but the families with known histories of seizures often go home with a plan from their neurologist, what they should be doing for their emergency. Diastat was the old tried and true. We saw lots of kids go home with this, just rectal administration of diazepam. I am seeing the significant rise of Nasalem and Valtico. So we're sending parents home with intranasal Versed or intranasal diazepam to use. I appreciate this for a couple of reasons. And mostly I think it's because I think families are that much more likely to give it. I don't think the families enjoyed giving a Diastat any more than we did, and nobody wanted to do it. And in all honesty, if your kid is seizing in the grocery aisle at Walmart, are you really gonna pull out your medication and administer it right there in a crowd of strangers? Like heck no, even if it's indicated. I think you're much more likely to pull out your Nasalem and give the kid the medication. So I think that this is a good thing that has come along. And then for some of the kids who are really prone to cluster seizures, whether that's just like 30 seconds long, but they'll just have long episodes of those, especially if you think about your more like kind of chronic neurology patients, that's common for them to go home with a Klonopin wafer that mom and dad will set on their tongue and it dissolves. The main thing for you to know about that is you might show up to an epilepsy patient and they got a bunch of white foam and froth in their mouth. And you're like, what in the world did you guys do to this kid? Like, oh, there's a wafer in there dissolving. And so just something to be aware of. Wanted to briefly talk about the ketogenic diet. We kind of touched on where this comes from. It's from kids who are continuing to have status prone events. And that's a little weird, right? So first of all, what is the ketogenic diet?
Ketogenic?
Yeah.
Low carb, higher protein, no processed pastas, potatoes, things like that. Easily absorbed carbohydrate.
Perfect. And high fat is the only other component of that. So yeah, so high fat, moderate protein, low carb. And why do we put seizure patients on that?
Decreases the seizure potential.
Absolutely, that's why it does it. So the theory behind this, and it is only a theory, is that ketogenic diet is a little bit like maybe rocket fuel for the brain. You have these dense, high lipid chains that the body's breaking down. You don't have as many byproducts from all the carbs. Also, you don't have the sugar spikes as much throughout the day. And so if you have that one irritable foci up here that just really loves to take everybody off into a seizure, well, if he's just a little bit happier, a little bit more content, maybe you're less likely to see some of those effects. And so that is the theory behind it. What is the hardest part about keto diet? So yes, staying on keto diet. I do have to laugh. I was teaching this a couple weeks ago and I said, what's the hardest part about keto diet? And their answer was not telling people you're on keto diet. I was like, that's pretty good. So I have to use that one a few times. No, the hardest part of being on keto diet is staying on keto diet. I mean, welcome to America. We got delicious carbs everywhere. And you go to a first grade birthday party and everybody else is eating cookies and cake and pizza. You're like, why can't I have some of that? And unfortunately, the risk of knocking them out of ketosis, and especially if that was one of the safety nets that was preventing them from seizing, they will knock themselves out of ketosis. We do tend to use it. It's really hard to keep a kid who eats by mouth on keto diet. We do use it on kids who are G-tube fed. That's a little easier because we can just control the milkshake that they get. And so you will see those kids on keto diet. We still have to be a little bit cautious in our treatment because there's sugar in things that we carry on the truck too, like oral Zofran, children's Tylenol, of course our D5s and our D10s. So always just kind of being very judicious in our use of sugar around that kid so that we also don't knock them out of ketosis. Vagus nerve stimulator is something you'll see chronic epilepsy patients receive. This gets implanted in the upper left chest. It goes about where a pacemaker would. It has a wire that comes out of it that wraps around the left branch of the vagus nerve running into the chest. And the prevailing theory behind this is it sort of acts like a metronome to the brain. So if once again you have that irritable foci who loves to lead the labor strike and take everybody off into a seizure, the rest of the neurons are distracted by this steady metronome-like impulse coming up the left branch of the vagus nerve. It's a small amount of electricity. It's given on a very set time schedule, however the device is set. The cool thing about them is that if you take this magnet that the patients will have and run it over the top of the device, it will actually give extra emergency stimulation bursts up the vagus nerve. So you are welcome to use that. So if you have an actively seizing patient with a VNS, you can grab their magnet and run it over a time or two. There are safeties built in. You can't give more than an extra burst like every 30 seconds or 45 seconds or whatever it's set at, so you don't have to worry you're not going to fry their brain running the magnet over the top or anything like that. Also, I wouldn't delay other treatment. It's kind of anecdotally been reported that they can have shorter seizures or abort the seizures, but you still want to be prepared once you're there to move towards your benzo treatments. Just know that you can try it a time or two. And that magnet does need to stay with them everywhere that they go because that's the only way they can do the extra stimulation, and that's also the only way to disable the device. You hold the magnet over the top, and that will turn it off. So where this works best, patients who really report best outcomes with this are patients who can feel their seizures coming on. They feel the aura. So they're sitting there in the room and they're like, I smell cinnamon, or I see halos around the lights, or whatever is kind of their clue. And they'll try swiping it a few times. So a pretty powerful device just from the perspective of it gives some patients a feeling that they can control their disease process a little bit. And so you will find that some people are pretty big adherents of it. So we all get dispatched right now to an actively seizing kiddo, and respiratory status is the main thing, right? Like we got to prevent the first killer, which is hypoxia and inadequate ventilation. So we really want to take a close look at that, gathering some of that history we were talking about. How long ago did this start? Do we worry that they had a fever? I know it's down here in the middle. I feel like that's almost like still one of my first most important questions. Like, do you have a history of this thing you were doing right here in front of me? And so let's see, let's talk about fever real quick. Why do I care if they have a fever or not? Febrile seizure, still most common cause of kids' first-time seizures, and so I want to know, okay, did they have a rapid spike in a fever here recently? One thing I like to point out to crews is we do not have the ability to diagnose febrile seizures in the field. It is a diagnosis of exclusion. You have to rule out a couple other things before you can say, yes, this was a febrile seizure. The only reason I emphasize that is first of all, hopefully we're not getting refusals out here in this world on febrile seizures, especially a first-time kid seizure. But just like you can't be like, oh, okay, that's just what this is. It'll go away. That'll never be a thing again. The other thing is I don't want you to give parents false hope sometimes. I think it's okay to say like, hey, it seems possible that this was a febrile seizure, but we should go up to the emergency department to double check. But sometimes you get to the emergency department and or admitted to the floor and all of a sudden we discover it was something else, right? Like it might have been meningitis or a complex febrile seizure or a kid who has an epilepsy that just we happen to find it because they were having a fever event today. So you don't necessarily want to be like, mom and dad, this is nothing, this will all be okay. We just, kind of don't want to give them false hope or a false promise there. Cerebral shunts. Why do I care if my patient has a cerebral shunt? It could be clogged. It could be kinked, obstructed, not working appropriately, and a seizure is one of the ways that we know that. High sensitivity for any kid with a VP or a VA shunt. Recent head trauma or non-accidental trauma, that is the fancy medical phrase we use to describe child abuse in this day and age. And so, of course, we're worried about a head bleed on those kids. And check their blood glucose. We do want to make sure we check that in any altered mental status patient. But just know that there's a lower correlation in the kids between that like hypoglycemic dystonic movement that you see sometimes in the adults. That's not as common in the kids. And also you have a bit of a chicken and an egg problem. So if they're demonstrating seizure-like activity, let's just go ahead and start treating this as a seizure. And then if we discover in the process of doing that, we're like, oh, your blood sugar's low. Well, we'll also treat that. But you kind of don't, is their blood sugar low and that's why you have the motions, or is their blood sugar low because they've been actively seizing for a while and they chewed through their glycogen stores pretty quickly? All right, so I get dispatched to a kid seizing. I always kind of want to keep, okay, what is worst case scenario here? Like who should I be really running fast and worried about? So any kid less than 6 months of age, I think we can all agree that sort of gives me the EBGBs. That's not typical. That's a lot of times where we discover either an epilepsy syndrome or a metabolic syndrome of some variety. First time focal seizures in a kid less than 18 months, that's atypical. That's usually a red flag. Of course, any seizure that lasts longer than 15 minutes, if you reach status, I'm pretty concerned about you in general. Persistent focal neurodeficit. So they stop seizing, but you still have a persistent deficit that is not resolving. That should be a huge red flag for you. The only exception to that is if you show up and the family says, oh no, we have a history of this, or we have a history of Todd's paralysis, which is a known deficit that persists up to 24 hours after a seizure event. Then and only then do I say, okay, I'm not as concerned about this anymore. But until then, if I see a symptom that won't go away, either, I don't know, they're still actively seizing in there, or maybe they had a stroke and that's what caused all of this to begin with. So that's a kid who needs to be evaluated pretty closely. Hemophilia, why am I worried about those kids? What do I think might have happened? They might have popped a head bleed, right? Like they might not have caught it off, that we might have an active brain bleed. Sickle cell, why am I worried about those kids? So you could be worried about some stroke-like effects if the sickling kind of desats them and prevents that. The other thing, and I would never have known this until I started teaching this lecture, but sickle cell patients are prone to pyridoxine deficiencies, better known to us as vitamin B6, and that can be a cause of a seizure. And so they'll actually receive vitamin B6 if they're deficient in that. Suspected head injury, of course, I'm worried about a head bleed, just like my hemophilia patients, and we already discussed why I'm worried about VP and VA shunt failures. So by definition, what is status epilepticus? Any patient who seizes more than 5 minutes or repeat seizures that they don't come back to baseline in between. I'm willing to bet like your protocols probably read that exactly like that. I'm willing to bet the job you had before this, they read exactly like that. And some of that comes from a study that we're gonna watch a video on here in just a couple minutes. But back in like 2010, 2011, they did the Rampart study, and what you saw is that a lot of our protocols became universal and ubiquitous at that time. Have you guys ever heard of any other time definitions of status epilepticus? So sometimes people will say 30 minutes, and they might be right. So there's actually kind of two definitions of status. There's emergency medicine's definition and neurology's definition. And so for neurology, any patient who seizes longer than 30 minutes, true status epilepticus. And why are they worried about the 30-minute mark? Because that's when we know that neurons start dying from the overexcitation and the discharges that are going on. Why do we not care in emergency medicine? Because we know just statistically, if you don't self-terminate your seizure by that 5-minute mark, you're very unlikely to without pharmacological assistance. And the longer we wait, the less likely our drugs are to work. So why sit around and wait for your patient to seize 30 minutes before you're like, oh, yep, now we know for sure that's status epilepticus. We might as well start treating back at the moment in time where we have a much better chance of stopping the seizure. So we know that delaying the benzo administration is makes it less likely that our drugs will work. Why is that? Because the longer that your patient seizes, they're de-recruiting GABA receptors, and you can push all the Versed you want in the world or all the Ativan you want in the world, and it's just floating in the bloodstream. It doesn't got receptors to grab onto to get the global CNS depressant effect. So waiting to obtain IV access, which is hard to do in kids in general, and especially seizing kids, can delay that time to drug delivery. And the longer it lasts, the less likely the drugs are to work. And so that's why we have really gone to recommending intramuscular Versed as our drug route of choice. Sometimes people ask about intranasal. Just the fancy answer from my neurology department was, we think the efficacy of intranasal Versed is 42%, which was really just a fancy way of saying we're not sure how much drug is like clinging to boogers or running down the back of the throat versus being absorbed in the capillary beds. And so we've gone to, hey, if they're actively seizing, they hit whatever your 5-minute mark or whatever your status mark is. Bigger kids, you of course can do deltoids, or the smaller kids, just get them on the side of the thigh and the vastus lateralis. And get the muscles on board and working. And yes, we need to do airway management, but a lot of times in seizure kids, you can maintain them by BLS methods. Good positioning, use your adjuncts as necessary, MPA, OPA, iGel. Sorry, I'll get rid of that all soon. And so, sorry about your ears. Which benzo is best? I think I already answered myself. Is Versed, but we're gonna watch this video on the Rampart study. I think it's important for a couple of reasons. So first of all, like I said, it kind of explained to us why so much of our treatment is the same on this, regardless of where you go and work. And also the other thing I think is actually just fascinating about it is was actually a good study done with EMS, not like, oh, we did this magical thing in the PICU and we think you guys should try it out in the field. They actually said, okay, how does this play out for you guys out here in the field?
Neurologic emergencies are one of the most common reasons for emergency medical services to be called. Among those calls, about 5 to 10% of all EMS runs are for patients experiencing a seizure.
Prolonged seizures that don't stop by themselves are quite dangerous. About 55,000 deaths per year in the United States are attributed to status epilepticus, to seizures that don't stop by themselves.
To study these and other neurologic emergencies and the best ways to treat them, the National Institutes of Health created the NET, Neurologic Emergency Treatment Trials Network. The NET studies are coordinated by the University of Michigan, with participation from hospitals and emergency medicine providers across the country.
Neurological emergencies is a huge problem in the U.S. and worldwide, actually. And about every 2 minutes, somebody in the U.S. dies from a neurological emergency.
The latest NET study findings, published in the prestigious New England Journal of Medicine, looked specifically at emergency treatment for prolonged seizure.
The University of Michigan is the clinical coordinating center for a multi-center clinical trial that we call Rampart, which is the Rapid Anticonvulsant Medication Prior to Arrival trial. Rampart was a study to look at the use of intramuscular injections rather than IV injections to stop seizures in patients who were having seizures that wouldn't stop by themselves when treated by paramedics. The purpose was to see if the IM shots were as safe and effective as the IV injections, but what was really exciting is that we found out that the IM shots were not only as effective, they were actually a little bit better at stopping seizures prior to arrival in the emergency department. It also showed that patients who got the intramuscular medication were more likely to be well enough to be discharged from the emergency department rather than admitted to the hospital than patients that got the intravenous medication. What would happen is paramedics arrive on the scene of a patient who's seizing. They would assess the patient by their local protocols. If the patient was eligible for the study, they would take out a special study box, open it, and the box would contain both an IM autoinjector, which is a rapid way of delivering medication intramuscularly, and an IV syringe. They would give the IM autoinjector and then start an IV. In each case, patients got active medication for their seizures. In half the patients, the active medication was in the IM autoinjector. In the other half of the cases, the active medicine was in the IV syringe. Neither the paramedic nor the patient would know which of the two syringes had the active medication. The implications of this for paramedic practice are pretty significant. This is clearly, I think, an evolution in the treatment of seizures by paramedics. It's not revolutionary, but it's a newer, better way of doing things that I think will be adopted widespread across the country.
Cool. So that was the study, like I said, I think about 2010, 2011, that really explains why so much of our stuff changed to the same back then. One thing that I like to point out, and especially we heard in the very first video, I don't know if you caught it, but when they were watching the neonate have the spasms in the seizure, you heard 0.1 milligrams per kilogram Ativan. And that's not wrong. That's what many of us had drilled into our heads, depending on when you went through school, 0.1 milligrams per kilogram of any benzo in a kid seizing. And that's not wrong, but that's the IV dose. We have to double it anytime you're going to do intramuscular or intranasal if that's your route of choice. And I only point that out because we still frequently see underdosing across the board in the kids delivered to the ED. So if you're going to take the time to break the box, pull out your drugs, treat the seizure, you want to make sure you're just hitting that right therapeutic dose so that you can know whether it's working or not. I'll point out this is even more important in this than, like, say, Narcan, and that's part of like why we think intranasal benzos isn't as good. Why? Because if you have an opiate overdose and you give Narcan, that didn't seem like it quite worked, and either 37 seconds later or a minute and 37 seconds later, you're like, okay, we'll just put a little bit more on there. With the kids, what you're trying to do is hit that specific dose and see if they stop seizing within the next 5 minutes, because that's what dictates whether you put the next dose. So you just want to make sure you're hitting the right therapeutic dose whenever you're doing that, because you're kind of making some clinical decisions based on that. And so just something to emphasize there. This is just an example of that. So this is across a 2.5-year period. Every seizure kid that was delivered to Glennon's ED that received a dose of benzos. It's probably a little hard to appreciate back there, but the gray line is just the kid's weight. Red is the correct dose that kid should have been given based on their weight. Blue is what they actually received. You don't have to be that close to see the trend that pretty commonly the red line is significantly higher than the blue. So a lot of underdosing going on. And so this was for all the intramuscular and intranasal administrations. And then this, over the same time period, was for the IV dosing for those patients. You still see kind of the same trend with one notable exception. So can we talk about that notable exception real quick? And you guys are going to nail this. What is the max dose when you're doing weight-based calculations for kids? The adult dose, absolutely. So this is just a gentle reminder that you don't keep doing the math, even if you have a 17-year-old that weighs 200 kilograms and administer 20 milligrams of Versed, because do you want to guess what that crew did for the rest of that goal? Bagged and failed in innovation, right? So I kind of already touched on febrile seizures, but just remember this still can be a big deal. There are complex febrile seizures in this world. They often mimic a status event, and so often indicative of a patient who has potentially other neurological problems going on as well, so or just going to be an epilepsy patient. So we definitely want to take them in to get evaluated, treat the seizure, but you can also treat the fever, so whether you do children's Tylenol or Toradol or whatever you guys carry in your protocol. There's always that awful moment in time. So you get there. First of all, actually, what's the greatest part about being dispatched to a pediatric seizure call?
Everybody shows up.
Everybody shows up. That's not bad. I would also argue that most of the time they're done seizing by the time you get there. So you usually get up and you're like, okay, he looks a little goofy, but he seems to be getting better and we'll all be okay. It's kind of rare for us to show up and they're still like actively seizing. You're like, oh man, and then you do all the treatment and you give your first dose of benzo and it doesn't work, and you give your second dose of a benzo and it doesn't work, and then they're still seizing, and that's like all of a sudden a bad feeling. You're like, well, crap, what do I do now? The answer to that does depend a little bit on where you are. Some services do carry Keppra or other second-line anti-epileptic drugs, AEDs, because you needed another acronym in your life. The other buzzword of the day, and I think you're going to see more of this, is the question of do we use ketamine? The only reason this isn't widespread is that the study that supported this had a grand total of 42 patients across a 5-year time period. It looked like it was successful, but that's just not enough patients to say, yes, we should change national policy. We are starting to write this into more and more STARS plans for kids that we know are status prone. First of all, because it seems like ketamine might have a few anti-epileptic properties unto itself. The other advantage of it is that it re-recruits the GABA receptors, and so now all those benzos that you put on board are that much more likely to be successful and start working. And so that is going to be STARS plan dependent, service dependent, but that's something that I think you will hear more buzz about moving forward.
So you're saying use ketamine as a secondary?
As a second line. Yeah, absolutely. So part of the reason, so we went to neuro and we were like, hey, like we have these cases of like EMS is having to stop because they gave 2 benzos, they couldn't stop it, they couldn't drive to tertiary cares or higher level centers, and they were just ditching to critical access hospitals. And we're like, you know, what else could EMS give as a second line anti-epileptic drug? And neuro's like, oh, okay, well, do they have Dilantin? Do they have Keppra? Do they have this? And we're like, no. We're like, what about ketamine? And they're like, oh yeah, ketamine works. We're like, well, why didn't you guys say so? And they're like, well, that's the 7th drug on our list. You know, after we get past phenobarbital and all those other ones, we say, hey, let's try ketamine. So it's actually been part of seizure treatment for decades. It just, they didn't realize that it was only the other drug that we carry out of the list of drugs. So the postictal state, we've probably all witnessed this in our careers. You know, they're sleepy, they're groggy. It takes them forever to come around. They have that unsteady gait. They keep trying to get up and walk off and fall down, and you're like, sit, stay here. So the hallmark of a postictal state, though, is that your patient should always be gradually making improvement back to their normal baseline. So I want you to tell me when you think she's done seizing.
Abby.
Is she done? Absolutely not. It's a trick question. She never stops. The postictal state does not include continued eye deviation, nystagmus of the pupils, either vertical, horizontal, rotary, whichever kind of nystagmus they're exhibiting, repetitive oral motor, whether that's grunting, hiccuping, quivering tongue thrusting, lip smacking, or continued rigidity in one of the extremities. That patient is still actively seizing. The gross part that you didn't like to watch might have gone away, all the big movements, but that brain is still seizing and still giving you some symptoms that it's actively seizing underneath there. So we want to identify earlier, we want to have that index of suspicion for our patient seizing, especially some of these atypical presentations. We want to be pretty aggressive once they cross our thresholds for treatment. You want to get after it because you are more likely to be successful the earlier you render that treatment. And this is just some of those numbers that back that up. You know, how successful was seizure termination? Well, if you got the drugs on board in the first 20 minutes, 86% termination, versus if they was past the 30-minute mark before they received their therapy, it only was successful 15% of the time on those frontline benzos. And so just to give you some numbers to back all of that up. So just a kudos, I have to shout out my former partner, Trish, who put a lot of this lecture together, and that was actually her daughter in the absence seizure presentation. And so just always give her a shout out for everything she did for STARS and EMS education. So any questions for me over that? Yes, ma'am.
Do you have any of your patients trying any like unorthodox methods, like CBD oil or anything like that, and is it working for them?
Yeah, so that's a pretty common medication that's prescribed to, especially like really chronic epilepsy patients. Lennox-Gastaut is super common for them to get the CBD oils. it's not nearly as big of a deal as it used to be. Like a lot of in the old days, like those families like felt like they were like walking into speakeasies, like go to this pharmacy in the bottom basement behind the building to get this, right? And nowadays it's just, especially we're so close to Illinois where it had already started there, because I used to have Missouri parents drive to Illinois to get it, and now it's just so prevalent that is a super common treatment still, especially though for some of the chronic epilepsy patients.
Is it working for them?
So I don't know that I have the good numbers behind that. I think especially like if you look at like say the Lennox-Gastaut syndromes, like it's in a lot of seizure treatments, what works for some patients doesn't work for others. And so some families will report, yeah, that's totally helping us, totally controlling, and other patients are like, no, we've tried 22 drugs you guys have given us, and like we're still seizing through that. And so probably a little bit patient dependent on that. Any other questions? Awesome. Thank you guys so much for your time today.